Assalamu alaikum. With the series of different presentations on laparoscopy, we move forward with another important topic, that is the out of the comfort zone and navigating the challenging pedicle dissection in laparoscopic nephrectomy. The critical challenge of hilar dissection in laparoscopic nephrectomy. We all know from the evidence that laparoscopic nephrectomy, whether simple or partial or radical nephrectomy, they have got better outcomes in terms of patients' morbidity, and as well as with the superior recovery and comparable oncological outcomes as with the open surgery. That's why, according to the American Urological Guidelines and European Association of Urological Guidelines, laparoscopic nephrectomy is now the gold standard. And wherever facilities are available, it can be a robot-assisted laparoscopic nephrectomy. Nephrectomy is a relatively easy thing if everything is normal, especially the hilum. But it becomes a little bit technically demanding and a high-risk step to dissect the renal hilum, that is the renal artery and the vein. And this is because this hilum is usually compact, having various vital anatomical crossroads like renal artery, renal vein, and the ureter. The difficult pedicle can be defined in case where there are anatomical variations in the pedicle. That is, whether the artery is single, whether it is double, whether it has branched early, or whether there is an accessory or aberrant artery coming from somewhere else. And the venous anatomy is usually variable in almost all the cases. And the other factors that are related to the difficult pedicle are the anatomical abnormalities and the inflammatory adhesions, like in case of simple nephrectomy, if the kidney is non-functioning secondary to PUJ obstruction, or stone in the ureter, stone at the PUJ, or if the kidney is previously operated, and if there is a reflux disease. So in all these conditions, there is recurrent and repeated episodes of pyelonephritis, which lead to inflammation of the pelvis, the renal pelvis, and as the renal pelvis, the renal artery and vein, they are in a closed compaction with each other at the hilum of the kidney. That's why this inflammation leads to fibrosis, and this fibrosis can lead to difficulty while dissecting the renal artery and the vein. And of course, if there is fragility in the renal vessels, like if there are repeated inflammations, and the artery and vein are usually stuck together, so dissecting them away from each other can lead to fragility or the rupture or tear in the renal vein especially. And in case of radical nephrectomy, if the tumor is very much advanced, if the tumor is really close to the hilum, if the tumor has involved the renal vein, or if there is a peripelvic renal sinus fat involvement, or if there are enlarged lymph nodes, so the pedicle really becomes difficult. So this lecture is about that. And mastery of this step is the hallmark of an expert urological laparoscopist. So before embarking upon the nephrectomy, in such cases, you must plan it before the surgery. So preoperative planning, it should be beyond the basics. That is, anatomy has to be clarified. So if you take a good history, if you do a proper clinical examination, like the conditions that I mentioned in in the difficult pedicle. Like, for example, there was a placement of a percutaneous nephrostomy, the patient had pyonephrosis previously, like if the patient underwent pylolithotomy or pyloplasty or a percutaneous nephrolithotomy, then of course this is going to be difficult. So you have it preoperatively in the mind. Then on examination, if there is a big kidney, a palpable kidney, if there are multiple scars in the flank region, that would signify that the pedicle is going to be difficult. So you can determine this by performing certain high-resolution cross-sectional imaging. It's a cornerstone for preoperative strategy. In this, you can know the exact location of the kidney, the exact shape of the kidney. You can see whether there is perinephric stranding or not, where is the artery, where is the vein, or is there is just a mass of lymph nodes around the pedicle, or if there is the propagation of the renal tumor in the renal vein or inferior vena cava. So this can be seen by high-resolution cross-sectional CTs. If you are performing a partial nephrectomy, in such cases you can perform a CT angiography with multiple phase contrast. So detailed vascular mapping and a road map of every key vessel is obtained by CT angiogram. And if there are allergies to the contrast material, then of course a magnetic resonance angiography can help you. What are the preoperative checklist, essential checklist to know about the anatomy? So vascular, if there is any accessory renal artery or accessory renal vein, that can be seen. You must look for the origins of the artery. Where is the artery originating from in the aorta? Is it coming from the aorta, or if it is a pelvic kidney, it will usually arise from the common iliac arteries. And you must try to locate the superior mesenteric artery in case of left-sided nephrectomy. Then the course of the artery, where is it going? Usually the most common location is the posterior-inferior location to the vessel, to the renal vein on both sides. But in the left side, one can see that the artery arises from the aorta, but it goes posterior to the renal vein, where there it crosses the lumbar vein as well. So that has to be kept in mind. Then there is gonadal vein and the adrenal vein, and on the right side you must see the length of the renal vein and of course accessory renal artery. So if there is early bifurcation, that must be kept in mind, because if you are dissecting very close to the renal hilum towards the kidney, you might encounter two arteries rather than, so because there is early bifurcation. So the root of the artery or the common stump is one, but there is early bifurcation, so one must be ready for that. If there's early bifurcation, one must look for the single root of the or the stem of the artery. By that way, you can deal only one artery rather than dealing two arteries, or dealing with one artery and missing another artery leading to some accident. And then, of course, retro-aortic left renal vein, which is called the pantaloon vein, is not very uncommon. And in that case, if you encounter such vein, do not try to dissect it behind the aorta, because dissection behind the aorta can be really dangerous. And the portion of the vein which is behind the aorta is usually very thin walled, so fiddling with that vein can lead to accident and a surprise on the table. So you have to deal it there and then, and do not dissect it too much. So that has to be ruled out by the imaging and the checklist. Then there are inflammatory changes like perinephric fat stranding, or the hilar sign, hilar fat sign, which I already mentioned, which indicates there's a dense adhesion and a challenging dissection. So you must be ready for it. Decrease your speed, try to focus and concentrate on the case rather than on the operation list. The slower you go, the faster you would be. So keep that principle in mind. The most difficult nephrectomy is that of the xanthoglomerular pyelonephritic kidney. The kidney is difficult, its dissection is difficult, as well as the pedicle is really difficult. And prior surgical intervention I have already mentioned in the history. So here are you can see that there are some variations here. Here we are seeing a left-sided kidney, and we can see two veins. One is going behind the aorta, the retrocaudal vein, and there is a normal vein. And here you can see the superior mesenteric artery as well. The simplified image of the same here, aortic vein. And then on the right side, again the same thing. You can see that there is a pantaloon vein. And here you can see that there are multiple arteries, three arteries, two coming behind the inferior vena cava and one coming anterior to the lower pole. And this may lead to, as we all know, lead to PUJ obstruction. And if the kidney becomes non-functioning and you are performing a nephrectomy, simple nephrectomy for this, you must look for an artery which is crossing the PUJ and going to the lower pole. And there are multiple veins. So this is the case here that I was discussing. Always look for this when you are operating on a non-functioning kidney in an adult. Look for this artery. You can see here the superior mesenteric artery, which is crossing right in front of the renal vein. And here are some other examples as well. Then on this image, one can see that there is a single artery having a long stump and a single vein. It's an easy one. But here on the right side, you can see that the tumor is located on the right, on the anterior surface, and is really very much close to the hilum. So the renal artery is one, the stump is acceptable, and then there is bifurcation. However, you can see here that there is perirenal fat stranding. So the vein is really going to be difficult because all the lymphatics are inflamed. Here again on the right side, you can see that there is extension of this renal pelvic mass into the proximal ureter, as well as there is extension of tumor thrombus into the inferior vena cava. This is the image of the same here. You can see it's a very difficult hilum. The IVC, inferior vena cava, is pushed anteriorly, so it will be really difficult. I would say almost not impossible, but near to impossible to operate this tumor. Here again, one can see that the renal vein and the inferior vena cava have got a thrombus. Here you can see an early bifurcation, a small artery to the upper pole, and this one is a normal hilum. Once again, a separate artery coming, so additional artery is coming from the aorta. The origin is from the aorta. Here, this is the same case here. Here you can see that the artery is located superior to the renal vein, but another artery which is originating from the aorta is even more superior. Here on this diagram, one can see that the renal arteries are, the origin is single, but there is so much early bifurcation that when you are performing a laparoscopic nephrectomy, in my opinion, you have to take them as two arteries rather than one. And here is a reconstructive image of the renal vein, the renal artery, and the superior mesenteric artery. So the intraoperative principles is that the dissection has to be a controlled one, and the art of hilar management has to be such that you have to plan preoperatively. So there are considerations on the right side. On the right side, the renal hilum is very short, especially the renal vein is really short. and the vein is really in close proximity to the inferior vena cava. So when you are performing nephrectomy, avoid overstretching the renal vein. We usually lift the kidney in order to separate the vein and then clip it. However, tenting of this renal vein has to be avoided, because if there is tenting of the renal vein, you have a tendency to apply a clip which is too proximal on the vein, and it may involve the wall of the inferior vena cava, especially the angle between the renal vein and the inferior vena cava is the site usually where it gets injured. While on the left side, the renal vein is very long. It is crossing anterior to the aorta, and it is crossing the aorta posterior to the superior mesenteric artery, or you can say that the superior mesenteric artery is perpendicularly crossing the renal vein. So the landmark is to identify and ligate the gonadal vein and the adrenal veins, because in the process, if one of them gets injured, the process becomes really dirty. So instead of taking a chance to avoid them, it's better to take them head on and ligate the gonadal vein and the adrenal vein, and then divide them so that the renal vein becomes more mobile. Okay, and dissection with caution to avoid traction or injury to the superior mesenteric artery. As I mentioned, that tenting of the inferior vena cava has to be avoided. Same is the case here. If you pull or push the kidney too much or the renal vein too much, there is a chance that there is a tenting of the superior mesenteric artery, and one may take it for renal artery and clamp it. Accidents do happen, and they have happened. So in order to avoid that, one must deal with the renal vein just lateral to the aorta, rather than crossing and dissecting the renal vein anterior to the aorta. In that case, you can avoid the mesenteric artery. And the second thing, which is very famous, is that if you find a renal artery too easily, it means it is another artery. It's not the renal artery. And the third thing is that whenever you start thinking that it's a renal artery and you are going to clamp it, before clamping it, you must ensure that the artery is going and entering into the renal hilum. So only then it can be considered as the renal artery. However, all these things can be sorted out before starting the pre-operative preparation, CT, angiograms, etc. And the sequence should be that the artery should be clamped first. So the principle that I follow right from day one till now is that I always try to dissect the renal artery first, as the vein is really superficial and anterior. So you will always encounter the vein first. But once you identify the renal vein, then you must look for the renal artery. And you should dissect the renal artery so much so, the complete dissection is not necessary, but you have to dissect it so much so that at least one clip is applied. So once you apply one clip, it will avoid congestion of the renal vein, congestion of the kidney. If you ligate the vein first, there is going to be a fearsome engorgement in the renal vein as well as the kidney, and there is continuous ooze from here and there, small vessels, because the drainage is stopped. So always try, because it's really tempting. The renal vein is usually right in front of you. So if you are trying to find an artery and you are not able to find it, then there is a temptation that, okay, let's do the vein and then I'll find the artery. No, never do that. Always and always remember, try to find the renal artery first and dissect it enough to clip it once. Once you do that, the rest of the procedure becomes easy. And after clipping the artery, 2 to 3 to 4 to 5 minutes later, when I dissect the vein, I always grab or close the vein with a non-traumatic forceps to see whether the vein is getting engorged or not. If the vein is getting engorged, it means that there is another artery that I have missed, or there was another branch of the artery that I have missed. So then I look for the second artery, and once you clip the arteries and there is no engorgement, then you dissect the renal vein separately, and then you clamp the renal vein and divide the renal vein. Once you divide the renal vein, it will go away, and you will be head on in front of the artery. Then you can complete the dissection of the renal artery proximally and distally, and then clip it and divide it. And the medial to lateral approach is that, of course, yes, colon has to be medialized, and especially on the left side, you have to mobilize the splenorenal ligament and also mobilize the spleen from the diaphragm all the way down to the crurum of the left diaphragm. Once you do that, the weight of the spleen will usually pull down the colon as well. So it will be easy to dissect the or deal with the hilum then. So reflect the colon medially to expose the great vessels, identify the mean renal vessels at their origin. Early and definitive control of the renal artery, minimizing venous engorgement, all has been discussed. Here you can see that it's a typical location of the renal artery, located posterior inferiorly to the vein, and here is the renal artery. So the renal artery is dissected enough so that one clip is applied, and after applying this one clip, the vein is clipped like this, and then it is divided, and the rest of the renal artery is then done. Then here is the left-sided kidney. This is the artery which has been clipped, and then the renal vein is done, and after that the artery is completed. Here you can see that this is the additional renal artery. The artery which was posterior inferior has been dealt with, but the vein was engorging and there was pulsation. So this is an unusual location of the artery, and that has been clipped, and now the vein will be clipped and divided, and the rest of the dissection will be easy then. Here again you can see the same. It's the right-sided renal artery, and this is the renal vein. Again the same thing on the left side, the vein, the artery, one clip applied to the artery, and then 3 clips applied to the renal vein, and then divided. Okay, this particular case, you can see that it's a left-sided kidney. The adrenal gland and pancreatic tail can be seen. The spleen can be seen here. Here you can see that spleen has been mobilized so much so that all of the hilum is visible. The trunk is too big, and there is a small artery behind the trunk, and you can see here that there are too many. There were 7 renal small veins which were draining into this single trunk, and these veins are really very long. The trunk was so big that I could not apply the hemolog clip. So after applying clip to the artery, I had to individually ligate all these veins and then divide them. So what is the technique for a short or fibrotic pedicle? At times you will see that you will not be able to dissect the renal artery and the vein. And if you try to overdo and then try to of course dissect the artery from the vein, there is a big chance that the vein will get teared and there will be a big disaster. So to avoid, after struggling for 5 to 10 minutes, you will realize that it's not possible to separate them. So in that case, a vascular stapler can play a role. So a green or a black load stapler for the pedicle has to be used. And the important thing for the application of the stapler is that you should use an appropriate size of the stapler. There is a mark on the stapler device which can tell you that staples are, I mean, the jaws are like big like this, but there is a mark here and there is a mark here, which can tell you that these staples are here on. So when you are applying it, you should not apply like this. You should apply like this between the two marks, number one. Number two, if this is the pedicle, the area posterior to the pedicle and area superior to the pedicle has to be adequately divided, so that when you are applying the stapler, nothing should come in the jaws of the stapler, because that will lead to malfunction of the stapler. And the second thing is that while applying it on the right side, you must look for the tip of the stapler. It should not be on the inferior vena cava. It should not be on the inferior vena cava. And on the left side, it should not be on the aorta or the superior mesenteric artery. So, and the other thing in such conditions is a hand-assisted laparoscopic surgery. They say that one hand is better than two. So even hand-assisted laparoscopic surgery, especially in the donors, is practiced in many centers. So that's a very safe approach. And the important advantages are that you can have a tactile sensation. And if there is any unexpected bleed or injury to a vessel, that can be controlled by a manual compression. And it can be used in obese patients, significant adhesions, and short retracted fibrotic pedicles. Suture ligation can be performed. The sutures can be extracorporeal or the intracorporeal, and hemolog clips nowadays are used. So how to manage intraoperative complications if there is a bleeding? So a bleeding protocol has to be from catastrophe to controlled resolution. So there are two steps. Number one, temporization. Always temporarily control the bleed. And after temporarily control, then you have to go for a definitive management. So stay calm, do not panic, and think really clearly. You must have a non-traumatic forceps in your one hand. If you are a right-handed surgeon, in the left hand, you can place another port as well. You can apply a good suction, you can apply compression, so that will temporize the bleed. So while temporizing the bleed and sucking out the blood that is already collected there to improve the vision and to look for the structures, you must identify the source of bleed, whether it is artery, whether it is vein. Is it a major vein or the renal vein or artery, and whether there is a complete transection or there is a small tear, there is incomplete transection. That has to be sorted out. Once that is sorted out, you have to dissect proximally and distally, and then you can control proximal and distal, and the bleeding will be stopped. And if there is still bleed, then what you have to do, you can increase the pressure as well. And after identifying the blood vessel, proximal and distal control, and if there is a small hole and you are performing, let's say for example, a partial nephrectomy, then you have to repair the vessels. And an important thing in such conditions, if it cannot be managed laparoscopically, then of course you have to convert. So conversion threshold has to be that the most important decision is when to abandon the laparoscopic approach. The indications for conversion are uncontrolled bleeding, loss of vision. At times there is a splash of blood from the vessel on the telescope, and you can't see anything. So for that you have to rush to conversion. It's the inability to safely secure the injured vessel, then you have to convert. And the crucial message is that conversion is not a failure. It is a sign of superior surgical judgment and a commitment to patient safety. So the patient's life takes precedence over the desire of the surgeon to complete the case laparoscopically. In short, leave your ego outside. So moving on to the next generation, we have to transfer the skills, the knowledge. you must have learned something in 10 years, and then you have to impart this knowledge within 5 minutes to your students. And that's how the process is evolving. So there has to be structured learning, haphazard learning, going through an experience and then learn a thing is not good for the student, because the patient safety is at risk. So the mastery of pedicle management is not innate, and it is learned, and it can be learned better in a structured learning program, and it requires a structured learning curve. So you have to go through the learning curve. So before achieving your learning curve, you have to do some simple cases in the beginning, and slowly and gradually progressing towards more complex ones that will give you confidence as well. And mentorship is extremely important. Experienced surgeons should guide their trainees through their first challenging cases, and they should provide real-time feedback and demonstrate key techniques. Video review is really very important. Record every procedure that you perform, and then later on go back and see what has happened. During the procedure, you must complete the procedure successfully. But once you go back and review the video, then you would think that the certain step which took me around 20 minutes could have taken me 5 minutes if I could have gone through that way. So it gives you a very good positive feedback, and once you go to the next case, that is fed in your mind, so you do that step like that. So a video review is really very important, a powerful educational tool to analyze dissection planes, making decisions, and to learn from difficult scenarios. So the conclusion and the ultimate goal is that the precision and safety is really very important. Preoperative planning is the foundation. A detailed roadmap of the vascular anatomy eliminates surprises on the table. And dissection is a controlled art, not haphazard. You have to make a plan. Like, for example, you have to medialize the colon. Then you have to identify the ureter. Then you have to dissect the ureter towards the lower pole. Then you have to dissect the lower pole. Then you have to go to the hilum, find the vein, and then find the artery, then dissect it and clip it, and then clip the renal vein and divide it. After doing that, you dissect the artery even more and clip it and divide it, and then you go to mobilization of the upper pole, and then mobilization of the whole kidney, and in the end you take down the ureter. So it is a controlled art. It's not haphazard. That you start with the upper pole in one case, in lower pole in another case, and you directly go to the hilum in one case, and so on. Precision and patience are more valuable than speed, and judgment is the ultimate tool. The ability to recognize an untenable situation and convert to open surgery is the hallmark of a master surgeon. Thank you very much for this presentation. I would like to show a few videos here as well to complement all this presentation and theoretical knowledge. So these are some videos that I would like to share. So the first one is that there are two veins. So the artery has been clipped first. Sorry, the single vein. The artery has been clipped first, and then the vein is clipped. And while cutting it, I'm cutting it in bits and pieces, because if you cut it in one go, it will just retract. The two ends will retract, and if there is incomplete closure of the pedicle, then it will start bleeding. Here the gonadal vein has been divided between the clips, and then because it was right in front of the artery, this is the left side, so we had to do the dissection, and here you can see that the artery has been identified and dissected enough, and a clip has been applied. And then you can see that the renal vein is clipped. It's really very important to see the hook posteriorly. It should be visible while you are applying it, because if it is not visible, it will usually go through the wall of the vein, and that will lead to bleed and tear and a cumbersome situation. Here again, we can see that there are two veins, one is behind and one is in front, but I am not really able to find the artery. Right from the knowledge gained by the CT, we can see that the artery is located between the two veins. So the first thing is to clip the artery, dissect it enough, and then clip the artery, and then see if the vein has collapsed. Yes, of course, you can see here that the veins are collapsed. We can see the posterior part of the hook, and then we apply the further clips and so on. So both the veins are then clipped completely. And then veins are divided first because it is not possible to apply scissor to the artery. Then is the fourth case. Here you can see that the vein and the artery are quite adhering to each other. However, we are able to dissect them. So reducing your speed will usually help you a lot during laparoscopy. So here you can see that one clip is applied on the artery, then another clip, so as to reduce the blood supply. The vein is completely collapsed, which made sure that yes, we have successfully cut off the supply. The posterior side of the hook is visible very clearly, and then in bits and pieces you cut the vein. And once we cut the vein, we found that there is another vein behind the artery. So it was a kind of surprise. We were not anticipating it. However, it was a near miss. We didn't end up in any accident. So we apply clips on the same vein, and then of course the same procedure. We just divide this vein, and the nephrectomy is completed. It was a radical nephrectomy. Then here you can see that there is one artery. We clip it, and then after clipping this artery, I check the vein. It was not collapsing, so we realized that there will be another artery. So we found another artery by dissecting it, and once we did that, now you can see that the vein is not distending. So we completed the procedure of nephrectomy. Now I come to the control of bleed and how to manage the such complications, the difficult pedicle. Here you can see that it's a radical nephrectomy, and there are multiple lymphatics which are inflamed. However, applying pressure for 5 minutes, we succeeded in controlling the bleed. Here you can see that we have applied clips to the arteries, but there are multiple veins. So here I decided to apply this external knot. However, you can see that the vein distended, and there was so much engorgement that the pressure inside the venous system of the artery led to dislodgement of all the clips. So the vein became so big that clip could not be applied, so I applied another suture. So here you can see that we have successfully achieved hemostasis, and we were able to complete the procedure laparoscopically rather than converting it. Here you can see that the gonadal vein on the right side is draining into the renal vein, so it had to be addressed. So when I applied the Liga clip, metallic clip, the applicator got stuck on the vein. So I had to use a monopolar diathermy first on the proximal part of the gonadal vein to control the bleed, and then I applied another clip so as to avoid any bleeding post-operatively. Then here comes another case. We missed one artery which was actually divided with ligature inadvertently, and luckily it bled during the procedure. So I found the stump of the artery, and then I used a bipolar forceps and bipolar the artery. Once the nephrectomy was completed, and we just clipped the divided end or the stump of the artery. Here we are performing a non-functioning kidney nephrectomy to pyelonephritic kidney. So we were dissecting the artery from the vein, and in the process the vein was fragile and there was a tear in the vein. So we kept calm, and I grabbed it with a non-traumatic forceps, then cleaned up all the area, and then I saw the source was from the vein, the site was located, so a proximal and a distal control was achieved, and the rest of the procedure was done. Here, partial nephrectomy was being performed, and there was a small tear. I tried to increase the pressure. Then I tried to apply a gauze, but the bleed did not stop. And in the end, we found that there was a small vein which got avulsed during dissection. Since we were performing a partial nephrectomy, and it was a small hole, so I decided to repair that hole with the Prolene 50 suture, and in the end we were able to control that bleed. And after controlling that bleed, we were able to complete the procedure of laparoscopic partial nephrectomy. So these are the different ways. Had it not been controlled, I would have gone for a radical nephrectomy, as I always take consent for radical nephrectomy while performing a partial nephrectomy. So in this case, we were able to control everything. And you can see a nice and clean field. Thank you very much for watching.